Good morning, everybody. I have a disclosure to make. I'm not Dr. Buscombe. He's not found. Maybe his comments yesterday, maybe he got deported or something. I don't know. But so it's my privilege today to very impromptu introductions for our two next speakers. Our first two speakers are from nuclear medicine physicians from Quebec. They're well known in their fields of PRRT and Gallium. Our first speaker, Dr. Beauregard, is a young up-and-coming PRRT and nuclear medicine expert from Quebec City. He has a vast wealth of knowledge from his experience in nuclear medicine, and he did a very excellent fellowship in the Peter MacCallum Cancer Center, which is one of the leading theranostic treatment centers in the world. So it's my pleasure to introduce the first of the speakers here.
Thank you, David, and I think I'm not that young. Or you're younger than me, I believe. Okay, so thank you for the introduction. So this is part of my presentation is a summary session of a presentation of what we've heard yesterday. I'll try to be not too repetitive, but I will be somehow. So first I will maybe go very quickly over the definition of what is PRRT. It's an internal radiation therapy using radiolabeled somatostatin analog, so the same kind of drug as octreotide we just heard of, but which we label with a radioactive compound to deliver the radiation to the tumor. It's a palliative treatment, palliative because it's very rarely curative, but it's for progressive or symptomatic NET that, of course, are not removable by surgery or completely removable by surgery, and they must be positive on octreoscan or gallium scan. It has been developed over about 25 years now in Europe, so it's nothing experimental per se, and it's despite only the recent evidence that is effective. And there has been a number of agent used, and the preferred to date is by far lutetium octreotate, also known as dotatate. I call it lutate, and lutateride will be the brand name of the upcoming commercial version of it. So an overview of the scans. We've talked about octreoscan, so that's on the left, and gallium scan on the right. But also there's the lutetium scan, which is the scan we do after a therapy. So it's not only a treatment, but it has some diagnostic value. And if you have a trained eye, of course, if you're a surgeon, you need that kind of image to see something. But a trained nuclear medicine, that was just a joke. A trained nuclear medicine physician can see, despite we have slightly less resolution with the lutetium scan. It's the same compound. It's octreotate, so it binds the same way to the tumor. We just change the radiation bit. One is for treatment and one is for just scanning. And we can see, so on the octreoscan, you don't see much of the bone lesions that you can see on the gallium scan, but you can see them on the lutetium scan. So often patients are selected with octreoscan because that's what's available. And I would say in the vast majority of patients, it's enough to select a patient for PRRT to say if PRRT would be indicated or not. But then it looks worse, the disease looks worse on the PRRT scan, but it's not because of progression in the interval, but because it's a better scan, like I said, almost as good as the gallium scan. So here, that's just a very quick summary of the 2008 paper by the Rotterdam group in Netherlands. And they showed at that time, which was, if you combine the efficacy figure, the survival figure, and the low toxicity figure, that was never seen in NET before. but that was only a phase 2 trial, so just a cohort receiving PRRT and no comparison through randomization with another treatment. So it was not deemed as to be strong, evidence-based proof of the efficacy. But from that time on, we knew that PRRT was effective. It was not just by, like I said, evidence-based medicine standard. It was also shown by the same group in a large cohort that it improved the quality of life. And actually, that might be the most important outcome compared to just looking at the scans and if the tumor shrinks or not. So it improved quality of life and symptoms in the majority of patients. And only recently, it's recognized by our oncology community as an effective treatment against mid-gut neuroendocrine tumor. And this data has been presented yesterday, so I won't go into much details, but maybe show the progression-free survival curve, which are quite impressive between lutetium octreotide and just high-dose octreotide. And again, with low toxicity. So it's now proven with the highest level of evidence. FDA approval is pending, and shortly after, there will be surely an application to Health Canada to have the same kind of approval in Canada. But it will be likely only indicated for mid-gut NET, whereas we know that PRRT is at least as good, if not better, in pancreatic NET. Just like we've seen results with chemotherapy that is more effective in pancreatic NET, these tumors are also more sensitive to radiation. So what is the current situation in Canada? So we had 1 hour of a 1 hour session yesterday about that. So I will summarize it here. It has been practice in Canada since 2010 under the Special Access Program, which consists of a case-by-case request or application to Health Canada, and it must be as a last resort option. So in the case of Special Access Program, you must document that the patient had at least somatostatin analog and everolimus or sunitinib, or in many cases, chemotherapy, and you don't have any other options. Since 2014, it's available under publicly funded clinical trials, so trials organized by physician and supported by hospital or provinces. So about the geographic coverage, so there's the Northwest Center in Edmonton, the Southwest Center in London, Southeast in Toronto, and Northeast in Canada. So it's not widely available, but it actually constitutes quite a good geographic coverage, in my opinion, for a rare treatment for a rare disease. We cannot expect to have PRRT in every single center where there is a nuclear medicine department. Otherwise, it will be just, many centers would treat one case per year or not even every year. I will summarize, so one slide for each center. So at the Cross Cancer in Edmonton, they have the largest experience in Canada so far. They have done it since 2010 in 248 patients. And initially under the SAP and they were the first to open their trial in 2014. Their protocol calls for 4 induction cycles, but in addition, they continue on a maintenance regime for responding patients. They do it as an inpatient procedure. They keep patient on average 24 hours. And Dr. McEwen showed very encouraging results. So with the progression-free survival figure not even reached at 59 months, which is quite impressive. And that's likely due to the maintenance cycle component, because after 4 induction cycles, If you don't do PRRT anymore, typically the tumor will progress again in a few months or years. And the toxicities are well within the known range from past experiences. Also, MIBG is available. It's a less frequent treatment. It's another radionuclide therapy that is less frequently administered since we have PRRT, but it's quite useful and even a first-line therapy in some neuroendocrine tumors such as pheochromocytoma and paraganglioma and also neuroblastoma in children. So it's still useful, and we cannot expect large randomized trial, but it will still be there for a while. The London Center is the second center to offer PRRT, and the second also in terms of experience. They treated, they gave 452 cycles, which should be around, David, around 100 patients or slightly more. Initially under the SAP, then under a trial that was inspired by Edmonton from 2014 to 2016, and more recently joined the Cancer Care Ontario trial since last January, following the same protocol. They have transitioned to a mostly outpatient treatment, and also they do offer still MIBG occasionally. The Princess Margaret Hospital is the first center to offer PRRT under the CCO trial led by Dr. Wang, who presented yesterday. They have administered PRRT to 15 patients so far since last August. Their protocol consists of a fixed activity at the first cycle and then the personalized activity based on the dosimetry study we do by doing serial scans after the treatment. And so that need calls for 3 days of scanning post-treatment. It's, I believe, an outpatient procedure. And Dr. Wang presented encouraging results yesterday, showing that they were able to increase the strength of the treatment or the injected activity by 57% in 57% of patients. And then the most eastern center to offer PRRT currently is my center at CHU de Québec, Université Laval in Quebec City, at the site called Hôtel Dieu de Québec. We started in 2012 under the SAP, and since last year under a clinical trial. In our case, all our cycle are personalized. Even the first cycle, we just do some adjustment based on the patient characteristics. And we also scan for 3 days after the treatment. From the start, it has been an outpatient procedure. And we also have a maintenance program for responder. There's no limit on the number of cycles offered. It's all a question of risk versus benefit on a case-by-case basis. If we think that there's more risk to give more cycles, then potential benefit will just stop and suggest another treatment. But from my experience, I've seen where I've been trained in Melbourne, we had one patient that received 17 cycles of PRRT over 13-year period. So it can show how good the control of the tumor can be on the long term with PRRT. And we also do occasionally MIBG treatments when needed. And the results I've presented yesterday is that it appears to be safe so far, and we also can increase the injected activity over the standard empiric regime. So this is a table summarizing all these features. So I've put my attention on some differences between the trials. And also I want to underline the fact that there's collectively in Canada, we have quite a significant medical experience about PRRT. So despite I highlighted some differences between trials, as patients, I think you need to consider these as relatively minor. All protocols are designed with safety and efficacy in mind. All the investigator and nuclear medicine physician wants the best outcomes for you. And we don't know at this time which approach is best. For me, I believe in more personalized treatment, but if you look at the figures Dr. McEwen presented yesterday about his protocol, which is different, it's quite impressive. So again, we don't know exactly what's the best protocol to date. And there's more common than differences across the trial. It's PRRT after all, and it's better than no PRRT. And the good news about having different protocol is it's all innovative trials in some way. We avoid barely replicating the trials that have been done in Europe and by industry. And they are somewhat less restrictive than the special access program in terms of access or industry trial where the eligibility criteria are typically very narrow, such as the NETTER one, which was only for mid-gut carcinoid. And all NET subtypes are eligible. It's publicly funded. Again, there's good and bad. What is good is there's no commercial interest, only the interest of the patient in that case. But unfortunately, because it's publicly funded, there's less resources. We don't have as many research personnel as we would like, and it's hard to fund a large randomized trial on such in such setup. So what's around the corner, and I will be as brief as possible. So PRRT is just the beginning. I think it will evolve over the next couple of years. So Lutathera is likely to be approved in Canada, but probably restricted to mid-gut NET. There's some other pharma, such as Ipsen, that are getting in the PRRT fields. Will Canadian sites be included in the trial? That's perhaps unlikely at this time, at least initially. So I think there's a role to continue those publicly funded trials for some time to guarantee the access first and also promote innovation. And then there's many other areas where we could improve PRRT through personalizing delivery, enhance efficacy with radiosensitizing approach, develop even better approaches to spare toxicity, such as the amino acids for the kidney, maybe that can be optimized. And we are working on some of these areas in Quebec City. So in conclusion, PRRT is one of the most effective palliative therapy to date for progressive or symptomatic NET in terms of response rate, survival, and quality of life. It's proven by evidence-based medicine criteria, efficacy against mid-gut NET, but the role and optimum treatment sequence is yet to be determined, in particular for other types of NET, and it's available today for all Canadian patients that have all kinds of NETs, and spread the word. You don't need to go into Europe anymore to get PRRT. And it's better to line up in one, even if there's a short waiting list, to line up in a Canadian trial, because that will show there's an increased demand, and that's how we can get more resources and funding to deliver it, is if we have a waiting list. If we have just a few slots and nobody is waiting for more, then no, it won't be a priority for funding. And in conclusion, it's really PRRT, the revival of the theranostic concept in nuclear medicine, meaning what you see on the scans is what you can treat. So thank you for your attention.
So it's my pleasure to quickly introduce, not least, but Dr. Turcotte. He's a leading authority in education in nuclear medicine. He's a well-known clinician in nuclear medicine and is also a clinical researcher with extensive SPECT and PET knowledge, and more recently he's opening up his own Gallium-68 trial, which is now, I get the feeling that it's open to many different people, even outside of Quebec. So it's my pleasure to introduce Dr. Turcotte to speak about Gallium.
Thank you very much. So in Sherbrooke, I'm wearing many hats. I'm a teacher, I'm a clinician researcher. Sometimes I'm trying to do my job as a nuclear medicine specialist. This morning, I decided to be your teacher. So you are all my residents. So I have a huge class this morning. So in a special class that I will name Advanced Molecular Imaging 101. So this morning, you will learn a lot of things of what we are going on, what is in the oven, what we are cooking in Sherbrooke to provide special imaging, especially the Gallium-68 scan. So at the beginning, you all recognize a regular CT scan with the beautiful images, the regular margin around the organs, very, very beautiful images. And in the middle, you have something abnormal, a lesion with calcification in it, straining on the bowel, which is a neuroendocrine tumor. And trust me, as resident, if you flunk, you will flunk your residency if you don't see that kind of lesion at your exam. You won't get your credential. But as resident, there's always somebody very smarter in the group telling, yeah, that's a huge mess. Trust us, we won't miss it at the exam. But make it smaller. Close your eyes and put it somewhere else. You will have a very hard time to find it out. So that's basically anatomical imaging. In anatomy, we are seeking for abnormalities, for lesions, are big or small, hidden everywhere. And with the medical imaging, a lot of times, the regular CT scan may be negative because lesions are too small. They are slowly growing, so even if you do many scans and you compare them, it's very hard to see the lesion growing over time, maybe over years, but certainly not over months. And they are very well hidden everywhere inside the body. So the regular anatomic imaging is not effective in all cancer, and that's true for all kinds of cancer, and especially for neuroendocrine tumor. So on the other end, it's not because you're seeing also a lesion that equal automatically a cancer. So the opposite is true. So it's always you see a lesion, is that cancer, is that not cancer, and we deal with that every day. So for us, we need something different from anatomical imaging that we call functional imaging. So functional imaging, we are not looking the organs, we are looking the cells, the behavior of the cells. Is that cell similar to the other? Are they working the same way? So that's very different because with functional imaging, you may have something of 5 millimeters, but if you know that it acts differently from the surrounding cells, it's because they are abnormal, even if they are very, very small. So for my resident, I explain the anatomic versus functional imaging like this. It's like playing Where's Waldo? You know that young guy with the T-shirt, red stripe, white stripes. A CT scan, it's like playing Waldo, and even the MR and the ultrasound, it's like playing Waldo in black and white. You have a lot of detail. You have all the detail you need. But the problem is everything are black and white, and you have to look very carefully where is Waldo and to find it. At the opposite, functional imaging, it's a bit more noisy. You don't have that much details. Images are not as beautiful as CT and as MR. But the point of functional imaging is that you are cheating. Because functional imaging will say, we don't know around the surrounding, but Waldo is there. But we don't know what is around. So what we are doing is we fuse the beautiful anatomic imaging from CT to the functional imaging, and that way we have a new test where you're cheating very quickly. You see Waldo in color, in a beautiful black and white with a lot of details, and that way you're able to pick up very small lesion without any interference from any other lesion that may look like cancer. So that's basically functional imaging, the kind of functional imaging that we are doing today. For doing functional imaging, we develop those tests in 3 steps. The first step is to find a highly specific target, so something specific for that kind of disease. And then we develop a probe that target that lesion. And we need to attach a light to track it down inside the body and to see where that probe is going. So let's say that it's a lock and key system. You have the lock, which is the target, the key, and you bring a light somewhere inside the body. So that's the principle of functional imaging that we name a radio tracer. So for targeting neuroendocrine tumor, there is a lot of targets. Some targets are around the cells. Some targets may be inside the cell. In functional imaging, we prefer the outside to reach something around the cell because it's much easier to bring something at the surrounding. So for neuroendocrine tumor, the best feature to use is the somatostatin receptor. And that's why we are talking a lot of things about that somatostatin receptor. So we use that target as our lock. Then we need to find the key. And the key don't need to be developed. It already exists. It's octreotide. That octreotide that we change a bit to create octreotoc, octreonoc, octreotate. Those are all somatostatin analogs where we just change the sequence of that protein to make it better, to make it worse, it depends. And then that you have your lock, your key, you need to find a way to track it down inside the body. So in nuclear medicine, we need to attach a light. That light will emit a signal inside the body that will show up exactly where the probe is going, so where are the somatostatin receptor. For that light, you know the Indium exam, and I will talk so far a bit later about the Gallium-68. So those are the images that a lot of people are having across Canada. This is the regular Octreo scan. More than 400 scanners are available on Canadian ground to do that kind of imaging. You see there's some resolution that's a bit noisy, but as Jean-Mathieu, you need a good nuclear medicine physician to read those kind of noisy images. It's a bit hard, but it's doing the job. So you see here a small, the uptake. This is the neuroendocrine tumor. Now, the problem with Octreo scan is you need a tumor of at least 1 centimeter to pick it out with the actual technology. So when you're talking about finding something of 5, 4, 3 millimeters, Octreo scan is not there and will never be there for a long time. So we need to rely on a new imaging and to change the light. So instead of using indium, we need to change the light to something using a better technology, giving us the possibility to reach that millimetric resolution. And the answer is Gallium-68. So a Gallium-68 it's the light. It's not the name of the exam. It's just the light that we inject to track the probe inside the body. And it comes inside the generator. So it's not a rocket science. So you just need to put water inside your generator. You get Gallium-68 at the other side. And you do your chemistry, and you are having a tracer. The problem with the Gallium-68 generator is it lasts about 9 months. So you need to change it every 9 months. It costs $45,000, and it's not transportable. And the biggest problem is the 68 minutes half-life. As a resident, I will explain you what is half-life, but you're supposed to know that. So the half-life, think that I have in my bottle 100 units of light that I want to play with it. 60 minutes later, if I leave my vial on the counter, I will lose 50% of my light in 68 minutes. So we are going against the clock when we're playing with Gallium-68 because at each 68 minutes, you lose 50% of your tracer. And 68 minutes later, you're left with 25% and so on. So you're just losing your tracer. That's why that every center that need their own generator and their own chemistry if they want to provide Gallium-68 scan for any purpose. The other problem, we need special scanner to do that kind of images. So they are not the 400 scanners available across Canada. There are 45 scanners available to do that across Canada. 70 are in Quebec. So that are big piece of technology. Not very expensive now. We are talking about $1.2, $1.5 million for those kind of scanner. And I expect, I really hope that Canada will double the number of those scanners because this is really the future of oncologic imaging. Those scanners can detect lesions at least 5 millimeters and lower than that, smaller than that. Do acquisition in 25 minutes. The new scanner, 15 minutes, and you're done. And it's 3D. Right away, when you leave the scanner, we have 3D images of you. With specialized software, we just navigate inside your body, looking at least 1,000 images, trying to track down where are those somatin receptors to see where are the lesions. So that's what we are doing. That's our job as imager, to see exactly where are the lesions. So a quick difference between octreoscan versus the octreotate. Now that you are expert, now you know that we are not using the same light. So we are not using the same type of camera. So we are more limited in technology. 68 minutes half-life for the gallium-68. We inject less dose also. So the dosimetry, so the dose absorbed by your body by the radiation is less with the gallium-68. The exam only takes 1 day. In 2 hours, everything is done, compared to octreoscan that may take 2 days, 3 days. So there is just the plus value of the octreotate compared to the octreoscan. So the images are very impressive. So we see many, many more lesions. And that's normal. The test was designed to do that, and it performs very, very well. Some of you already had also a Fdg exam. The Fdg exam, a lot of time when you have a G1 and G2 neuroendocrine tumor, the Fdg scan is not the best scan to do because it can be easily falsely negative. This is an example here where the Fdg is absolutely normal compared to the octreotate showing many, many lesions. But that's a good thing because when Fdg doesn't have any uptake, it's a good sign, it's a better prognosis. So the disease can be more controlled with the somatostatin, can be more controlled by the PRRT. So that's a good sign to have an Fdg negative exam. We did 156 cases in Sherbrooke since last June, and every case is just a surprise over surprise over surprise. We discovered things that were undiscovered on every patient. As an example here, that man was operated, so a surgery for a bowel resection, and we did the octreoscan and discover a unique metastasis in the heart. So it may look something rare, but in my experience, it's the second time I discover a metastasis in the heart. So I don't know, but maybe it's something more often than rare. So that's the kind of images that can lead to that kind of diagnosis. The impact on therapy is impressive. You may expect a change in therapy in more than 40% of cases. So it's like flipping a coin. A lot of times you will discover more lesions that will change the treatment. Sometimes you may be declared as metastatic and they are not metastasis at all. So this is a good example here. This is a 56-year-old male with a small bowel neuroendocrine that was followed by CT scan for a slowly growing lesion. And as resident, you all know that the best way to cure is to cut it out, to remove the lesion. So for that man, we perform the octreotate scan. Easy to see that there is an uptake in the lesion. So this is a no-brainer. This is really a neuroendocrine tumor. But if you look more closely in the mediastinum, so between the lungs, behind the heart, there are a small foci of uptake. So you zoom, and you discovered a 5 millimeters lymph node expressing somatostatin receptor. So this is a metastasis. Very far from the primary, well hidden in a place where nobody will find it. So Sherbrooke developed a trial that we name Phase 2 study to measure the safety of Gallium-68 dotatate PET-CT in the diagnosis of tumor expressing somatostatin receptor. That's a long name, I know. But the thing to remember is we need to do a clinical trial to offer you the Gallium-68 scan. And to make it the easiest way possible, the only thing that we ask to provide when you perform that kind of scan is just to answer a quick question. What do you feel after the injection? So that's the trial. So somebody will tell, oh, the needle hurt a little bit. Somebody will tell, oh, I'm extremely happy to have your scan. So we are just gathering the side effect, nothing else. So the study is open for the pediatric because some kids are having also neuroendocrine type of tumor. So we have to, we have include them into the study. Adults with a proven or a suspected SSTR, so somatostatin receptor expressing tumor. That could be a patient with Fdg negative, octreoscan negative, before PRRT to measure the response to treatment, follow-up, any kind of situation where your physician is having a clinical decision to make. So those are all the kind of tumor that can be scanned with the Gallium-68 octreotate. The one in red are the one I already scanned since the last year. So there is many indication already scanned in Sherbrooke. As exclusion criteria, the most used criteria was the patient refusal to participate. Okay, that's very unbelievable, but when we exclude somebody, it's because the patient exclude it by itself. So he refused to have the scan. So please, if we ask you to come in Sherbrooke to have that scan, please accept and make that 2% getting lower. I don't want it to get higher. And the good things is about the fundings. So for all Quebecers, the exam is free. Many Quebecers already had 2, 3, and even 4 gallium octreotate scans since last year. And now we have an agreement also with CCO to provide that scan in Sherbrooke for the Ontario patient. The only thing is that CCO need a request from your oncologist. They will revise the indication, and if they accept, they send us a fax, and right away we call you and we prepare you for the exam. That's the way we are doing. So first, we need to confirm that you are eligible for Gallium-68, so in one of the inclusion criteria. The oncologist need to advise you and seek the approval that somebody from our hospital will call you for the exam. For Ontario patient, they need to fill the CCO form, the regular PET Fdg exam. And Quebec, they just need to fill a request and send it by fax. And that's done. And the day of a scan, there is no fasting required. We ask you to sign the consent form. We inject the octreoscan. You wait 60, 90 minutes. We place you under the scanner. It takes 25 to 30 minutes, and you're done. You return home. Nothing else to do with the research study. And if you feel something in the next 24 hours, like an adverse event, you just need to call us, and we repatriate into the registry the adverse event. So, yeah.
Quick question: do you have any guidance for when the last octreotide injection should be? Or?
Yeah. So the guidance, that's very easy. We ask when is the next injection, and we provide the scan the day before. So we are aware of that, and we do that special preparation for that. So in Sherbrooke, we are already overwhelmed with many requests. Like just Friday, we received 15 requests for the scan. So we are in a hurry to work with Jean-Mathieu to bring other centers in Quebec open as soon as possible. And we are also talking with Halifax also to bring the clinical trial in their center because we need more and more sites to provide those scans. And if you have any question, you may contact my research assistant, Elena Santos. Some of you maybe already know her. She's very kind. So if you have a question, ask her. She will answer. Thank you.
So I think we're over time, but I think it's a break, so I don't know if you want 15 minutes. And I think I'm asked you to fill out evaluations if you can.